good morning or good evening, depending upon the time you are going to view this video. Today, I'm going to talk about capnography. Where are we after 3 decades of its introduction into clinical practice? Here, I'm also going to recap some underlying physiology of capnography. Now, the goals of this lecture are four. Recap some notable developments in these 3 decades of capnography. How and where did capnography find applications beyond the four walls of operating room? Understand the physiological basis of these applications and interpretation of capnography under some unusual circumstances. The three underlying physiological concepts one should always remember about capnography are: capnogram is not a line diagram, but it is a visual representation of BQ mismatching of the line, the end results of Riley's 3-compartment model in the lung. Number two, the alveolar plateau has an entitled CO2 somewhere embedded in the phase 3 or the alveolar plateau of CO2 curve. We do not know exactly where on the plateau is the entitled CO2. The third is I will talk about volume capnography because it is opening up of a new era of determining Bohr's physiological dead space. Now, if you look at the overview of capnography, this is the anesthesia circuit in the operating room with the ventilator and the breathing circuit, and this is the patient circuit, and in between these two circuits is a critical junction of the airway or the endotracheal tube, and this is where we measure capnography or we use capnography. Therefore, when you are monitoring CO2 at this critical junction, it gives you the entire perspective of the anesthesia circuit on one side. It also gives an entire perspective on the patient's right from the metabolism and CO2 production of carbon dioxide, its transport via heart to the lungs, and elimination from the lungs and into the anesthesia circuit. Capnography is not a direct monitor. That means it is not going to tell us straight away what is the cause of an abnormality. Rather, the clinician should have sufficient knowledge to interpret the clinical circumstances and come to a reasonable conclusion of the etiology of an abnormality in capnography. Now, when you look at the landmarks in the last 3 decades, there are a lot of changes that have happened in the terminology of capnography, capnography in pregnant subjects, capnography during laparoscopic surgery in pregnancy, pediatric capnograms, and outside of the operating room, particularly the CPR, the procedural sedation, intensive care units, transport of patients within the hospitals and in between the hospitals, and postoperative management. And so these are some of the landmarks that have taken or the landmark developments in capnography in last 30 years. Now, when you look at the nomenclature of capnograms, in the past, there are several nomenclatures were used to demonstrate the various phases of capnogram. PQRS, ABCD, etc. But in 1995, we came up with a standard terminology for capnography, or for capnograms, namely an expiratory segment and the inspiratory segment, and phase 1, phase 2, phase 3. Phase 1 is the dead space gases. Phase 2 is the dead space to alveolar gases. It's a transition from dead space to alveolar gases. And phase 3 predominantly represents the alveolar gases. And when the next breath starts, the CO2 concentration decreases to baseline, which is 0. And this is called as the phase 0 or the inspiration. The angle between phase 2 and 3 is the alpha angle, and this gives you an idea about the ventilation perfusion matching of the lung, because the alveolar plateau represents the CO2 evolution from the alveoli with various VQ ratios. And the beta angle between the phase 3 and the downward stroke represents an idea of any rebreathing. If there is no rebreathing, the angle is almost 90 degrees. Now, where does expiration end on that alveolar plateau, particularly in a time capnogram? Now, there are two capnograms here. One capnogram you can see here, which looks like a very normal looking capnogram. And this looks like a capnogram with a very prolonged expiratory plateau. We assume that the expiration ended somewhere here with the untitled CO2, and this is the inspiratory phase here. Whereas in this capnogram, where is the untitled CO2, or where did expiration end? And this is going to be very difficult to find out on a time capnogram. Now, because in a normal capnogram, when you take the next inspiration, the CO2 concentration decreases dramatically. Whereas when the expiration is prolonged, particularly when the respiratory rate is slow, we really do not know where the expiration has actually ended, and the remaining is the end expiratory pause. For example, as shown in this capnogram here. Now, normally when the lungs empty out, there are fast alveoli and slow alveoli. The slow alveoli empty gradually, as seen by this green line, and the fast alveoli, they empty out rapidly initially and then slow down towards the end of expiration. Combination of slow and fast alveoli gives you the alveolar plateau. Now, generally, most of the expiratory gases flow out during the 1/3 of the expiratory time. That means the gases rapidly empty out of the lung. So in this capnogram, probably the lungs must have expired somewhere here or here, and the remaining is all end expiratory plateau. But we cannot normally make out where expiration ends in a normal time capnogram as is used currently. This is the expiratory plateau, and as you can see, particularly when there's a respiratory rate is slow, you can actually see some wavy waveforms towards the end, and these actually represents the pulsations from the beating heart, where the CO2 is actually moving back and forth within the airway and the sensor. Now, these are the two capnograms which I have shown here. Now, if you plot the expiratory flow and inspiratory flow and superimpose them on these time capnograms, this is how it looks. As you can see, this is where the expiration ended and the inspiration started, so it looks like in a normal capnogram. Whereas here, this capnogram also looks normal, but however, when you superimpose the respiratory flows on top of this, the expiration has ended here and inspiration has started here. So that means this point, this is where the end expiratory CO2 is, and the remaining is all the rebreathing because it is in the inspiratory phase. This is probably because of malfunction of the inspiratory or expiratory valves. So plotting the flows, the respiratory flows over the capnogram actually makes a lot of physiological sense while interpreting capnograms. Now, this is a capnogram where you can see this is the expiratory plateau and there is a sudden dip. This is because of the forward flow during inspiration from the ventilator, which is actually diluting the expired gases. So the expiration probably must have ended here. This is the expiratory plateau probably, and or the expiratory pause, and during which time it is diluted by the forward flow during next inspiration, giving rise to this, this variety of capnogram. Now, what about capnography in pregnant patients? Normally, the end tidal CO2 is below the arterial CO2 by about 5 millimeters, which we call it as arterial to end tidal CO2 difference in non-pregnant subjects. In healthy subjects is about 5 millimeters. However, during pregnancy, this difference is narrowed to almost 0 or to 1 millimeters. And we did a couple of studies way back in 1986 and 87 where we measured the arterial to end tidal CO2 difference during cesarean sections and found this difference to be 0 to 1 millimeter. And this is of particular value because during cesarean section anesthesia, we can, if you maintain the end tidal CO2 around 32 millimeters, the expected arterial CO2 would be around 32 millimeters. Whereas if you follow the non-subject rule where the difference is 5 millimeters, if you bring your end tidal CO2 to 28, then your arterial CO2 will be also 28, which is not good for the uterine blood flow because the uterine blood flow begins to decrease when the arterial CO2 decreases below 28. Therefore, these studies highlight that since the arterial to end tidal CO2 difference is 0 to 1 millimeter in pregnancy, it is necessary that we maintain the end tidals around 32 during cesarean section anesthesia. We also did a couple of studies measuring the physiological dead space during cesarean section, and what we found was the alveolar dead space is actually decreased during anesthesia for cesarean section. Now, another landmark observations were the arterial to end tidal CO2 difference during laparoscopic surgery in pregnancy. As we all know that we do many cases of laparoscopic surgery, particularly the cholecystectomy during pregnancy, and we are insufflating CO2 into the abdomen. And therefore, it is necessary to know what is the arterial CO2 during insufflation and anesthesia. Now, initially, based on the animal studies, particularly the pregnant ewes, an arterial line was advised during surgery, during laparoscopic surgery in pregnancy because of the fear of respiratory acidosis. However, subsequently, when we did a human study where we actually measured the arterial to end tidal CO2 difference during laparoscopic surgery in pregnant women, we found that this difference is generally between around 1 to 2 millimeters, and therefore maintaining end tidal CO2 around 32 millimeters is sufficient enough for us to know that the arterial CO2 is around 32 to 34 millimeters of mercury, and therefore an arterial line probably is not required, at least based on this study. Now, what about pediatric capnograms? Normally, you can get this variety of shapes of capnograms in pediatric population and infants and children. They may look like this, they may look like this, they may look like this, they may look like this. This is because of the response time of the currently available monitors may not match the faster respiratory rates and low tidal volumes. However, the new technologies of capnography have made this possible to get normal capnograms even in small neonates with a very small tidal volumes because of a better response time of the analyzers, particularly the microstream technology with an aspiration flow rate of 50 ml from the airways is a good addition to our armamentarium. So the point here is the newer monitors that are currently available in the market that are very, very suitable for measuring CO2 waveforms accurately, even in very small children with small tidal volumes and faster respiratory rates. So these are some of the landmarks that have happened in the anesthesia-related areas of capnography. Now, these are the other areas where capnography has become popular, particularly the CPR, procedural sedation, intensive care unit, postoperative pain management, and transport of patients. And all these categories, they come under the capnography outside the operating room. So the capnography has spread from the operating rooms to all these areas around the operating room. And that is why you see capnography being used in the emergency department, during endoscopy, during angiography, and in the cath labs during sedation. Now, I did write an article on capnography outside the operating rooms for anesthesiology, for the journal Anesthesiology, and this is a free download, and I encourage all of you to read this article on capnography outside the operating rooms. Now, if you look at the ACLS algorithm for CPR, capnography has been strongly recommended and introduced into the current ACLS guidelines. Now, if you look at or if you understand the physiology of capnography, as you know that the lung has got varying VQ ratios with a varying CO2 concentrations because of the varying VQ ratios. When these gases are expired out and measured, you get the typical alveolar plateau as shown here. The height of the CO2 curve is dependent on the ventilation and perfusion, and of course on the ventilation perfusion matching in the lung. So the height of the capnogram is very, very dependent on the cardiac output for a given ventilation. This is the principle that is used in capnography in CPR. This picture actually demonstrates the relationship between CO2 values and the cardiac output. A cardiac output of 2 liters generally corresponds to an end tidal of about 20 millimeters, and a cardiac output of 4 to 5 liters will correspond to an end tidal of 32 to 36 millimeters of mercury, provided the ventilation is normal for a given patient. And an abrupt decrease in end tidal CO2 for a given ventilation suggests probably a drop in cardiac output if your monitoring device is performing well. Now, this is an example where the end tidal CO2 is about 37 millimeters and with a cardiac output of 5 millimeters during surgery, and there is a sudden hemorrhage from the liver because of liver resection, and the cardiac output decreases, the end tidal CO2 decreases for a given ventilation. So this is an example. And if we do not take corrective measures here, this is going to lead to a disaster as shown in this diagrammatic picture. Now, when there is a cardiac arrest during the case and subsequently it is revised, a trend capnogram actually looks something like this. The end-tidal CO2 decreases because the cardiac output is decreasing. Then there is a cardiac arrest. We are resuscitating the patient here, and the cardiac output gradually increases because after successful resuscitation, and the end-tidal CO2 increases gradually to normal with normalization of cardiac output. And this is the principle that is used in CPR. Capnography acts as a rescue device in CPR, and it helps to pull the patient from the death valley. Capnography has been demonstrated to be the most reliable method of confirming and monitoring correct placement of endotracheal tube. If there is no CO2 waveform during CPR, we have to rule out an esophageal intubation because the chest compressions produce a cardiac output, adequate cardiac output that can actually produce CO2 blips on the capnograph waveform. Because as I said, that a 2 liters of cardiac output generally should produce the CO2 waveforms of 20 millimeters of mercury. And 2 liters is the normal cardiac output that is expected during a CPR. Now, in England, what they have done is they have advocated the use of capnography for all CPRs because the coroner actually found esophageal intubation during CPR, and they actually advertised to all their members that esophageal intubation undetected because capnography is not used is now labeled a never event in the National Health Service in the United Kingdom, with capnography being mandated to be used during CPR. So it is a good step to enhance the safety of patients during cardiac arrest. Now, if you do a good chest compression and with an effective and produces an effective CPR and generating about 2 liters of cardiac output, the end-tidal CO2 should be around 10 to 20 millimeters of mercury or even greater than 20 millimeters of mercury. If the end-tidal CO2 values measured after initiation of ACLS are less than 10 millimeters, despite doing a good CPR technique, then it is associated with poor prognosis. And again, I'm emphasizing that how cardiac output is directly related to CO2. When CPR is being administered and there is a sudden return of spontaneous circulation, the cardiac output increases. And as shown in the earlier diagram or the earlier animation, there is a sudden increase of CO2. And this indicates return of spontaneous circulation. So this is another advantage of using capnography during CPR. We know when spontaneous heartbeat has started with good cardiac output. And that is the reason why many institutions, when they go for code outside of the operating room, they carry the capnograph so that we can measure the CO2 waveforms during resuscitation. And of course, we can also add a video laryngoscope because we do not know which patient is going to have difficult intubation during CPR. This is a very interesting case report where this person suffered a cardiac arrest and was resuscitated in the supermarket. They administered several shocks and they initially thought that he was not going to be resuscitated because the heart never started despite continuing CPR and with shocks. However, one of the nurses who came to resuscitate this patient has substantial knowledge about capnography, and she realized that when they measured CO2 during resuscitation, the end tidals were consistently around 25 millimeters. When she called the physicians from in the emergency room and seek their advice, they said if the end tidals are pretty good, continue resuscitation, and they were able to give several shocks. I think about 13th or 14th shock, the patient's heart is revived after 96 minutes, and he goes to the hospital and gets an angiography and a big plaque removed from the coronaries, and he makes a very good recovery with neurologically intact. And this was one of the news in the television channels. And there they said, capnography, it measures how much carbon dioxide is being expelled from each breath. The information helps doctors and emergency medical personnel determine whether a patient is hyperventilating or having a heart attack in a lay terms, in a layman terms. It also helps them to decide how to treat an asthmatic attack. And this is important because the CO2 waveform is abnormal during asthma, as we know, and to determine whether CPR is working. Remember, this is a public forum news channel on capnography, on the value of capnography. Now, when do you stop CPR? Well, in that case, it was 96 minutes. It is still uncertain presently, but however, capnography during CPR is actually being used as a prognostic value in determining whether patients should be cooled after resuscitation from CPR. Now, what about sedation and capnography? Now, in about 211 or so, the ASA and Association of Anesthetists of Great Britain and Ireland revised their standards and included that capnography should be used to monitor patients during procedural sedation, particularly during moderate and deep sedation. And subsequently, many societies across the world, as shown in this slide, have actually followed the suit and implemented capnography in their armamentarium during sedation. And this is a small brochure from England, and where it says that using capnography for all anesthetist-led sedation to improve patient safety. Capnography, the monitoring of carbon dioxide in the breath, is used to monitor patients' breathing and is the only way to make sure patients are breathing adequately while they are asleep or sedated. So this has changed our philosophy, and we all use capnography now during sedation, not only in the operating room, but outside the operating rooms. Now, why was this introduced? It is introduced because of 6 reasons. It is difficult to predict how an individual will respond to an administered sedation. We know as anesthesiologists and sedation providers. Incidence of hypoxia is less if capnography was used to monitor ventilation, based on some studies. Capnography, when used in conjunction with pulse oximetry and visual inspection of the chest, detected respiratory depression 17 times more often than without capnography. Capnography forewarns of impending hypoxia by about 5 to 240 seconds. So it is almost like 4 minutes. It gives you a warning that if you are not going to implement corrective steps, the patient may become hypoxic. Capnography triggers an early intervention and decreases the incidence of oxygen desaturation. And this is no brainer. As anesthesiologists, we see this all the time. And administration of supplemental oxygen delays the onset of desaturation following apnea. And therefore, relying on pulse oximetry alone will delay intervention. And this is one of the important points to remember when you administer oxygen during sedation. Now, we all know that when you are administering oxygen and then measuring the CO2, your CO2 waveforms may look abnormal, but that is fine. These are the baseline capnograms. What is important is a change from the baseline. As you can see here, probably the respiratory rate has decreased because of sedation. And in this capnogram, the height of the CO2 waveform has decreased because of hypoventilation or probably respiratory obstruction. So what is important during sedation is a change from the baseline to during sedation. Now, when I monitor CO2, what I generally do is I put a nasal cannula, as you can see from this red arrow, to monitor CO2 alone and put an oxygen mask. And you see how normal looking capnograms you get. And I actually make a small hole in the mask so that the endoscope can be introduced through that hole, and the procedure can be done, and your capnograms are more or less, they look normal. This is a differential diagnosis of capnography during sedation. This is an algorithm, and if you go to my website, capnography.com, and go under sedation, you can find this algorithm, and you can study this algorithm and how to use capnography during sedation. Now, what about capnography in ICUs? A landmark study which is the National Audit Project, or what we call as NAP4, by the Royal College of Anesthetists and Difficult Airway Society, determined that a major complication of airway, they studied the major complications of airways in 3 places: the operating room, the emergency department, and the ICU. During anesthesia, there were 16 airway-related deaths in 3 million anesthetics monitored with capnography. So it is 1 in 180,000. In the ICU, there were 18 airway-related deaths in 48,000 patients receiving ventilation. And the incidence is 1 in 2,700. And this is an important thing. 74% of the incidents were considered preventable with continuous capnography. If you go back to 30 years before the introduction of capnography, similar statement was made. When they did the ASA closed claim analysis, they said that probably about 70% of incidents could have, brain deaths or the hypoxic events could have been prevented with continuous capnography. So a similar finding also has been demonstrated in the ICU. Therefore, they advocated the use of capnography from 25%, which was at that time 25% of the ICUs used capnography during that time. They wanted to increase it to 100% because the risk of encountering a major airway complication in ICU is about 66 times more often than in the operating room. And that is why capnography was recommended to be used in all ICUs. And particularly, as we know, majority of the cardiac arrests in an institution or a hospital occur in the ICUs. And I just explained how capnography is a useful tool during CPR. So this NAP4 study, what were their final conclusions are: the capnography should be used in all patients for intubation irrespective of location. Routine use of continuous capnography in all intubated patients or with tracheostomy. If not used, state clinical reason. Train all staff in identification of abnormal waveforms. As I said, capnography requires certain amount of understanding for proper interpretation and use in clinical practice. Checklist of intubation and tracheostomy preparation, equipment, drugs, etc. Of course, all this checklist is also required. So these are some of the recommendations they came up. And they also said that it will take a couple of years for the implementation of capnography across all ICUs in United Kingdom. But now what I understand is the use of capnography is almost 100% in United Kingdom. Now, volume capnography and Bohr's physiological dead space. Now, we all know that Bohr's initial physiological dead space calculation was the alveolar PCO2 minus expired PCO2 by alveolar PCO2, and roughly is about 0.3. Now, since it is difficult to determine alveolar PCO2 because it needs an extensive methodology using Douglas bag, Enghoff modified it and he supplemented the alveolar PaCO2 or the alveolar PCO2 with arterial PCO2. And this is what we have been using all these years, probably for a century now. However, with the advent of volume capnogram, we are able to actually determine all the components of a tidal volume, namely the effective ventilation. This is the physiological dead space, the components being anatomical dead space and alveolar dead space. And somewhere on this alveolar plateau is the mean alveolar PCO2. And volume capnography is able to give us this value of mean alveolar PCO2. And therefore, now actually we are in a position to determine the original Bohr's physiological dead space breath to breath during ventilation. Since Bohr's physiological approach uses the alveolar PCO2, it is slightly smaller than the Enghoff's approach because it uses PaCO2. Because the arterial CO2 not only takes into the effect the dead space, but it also takes into the effect, effectively it takes into effect the shunt fraction also. So, Bohr versus Enghoff's physiological dead space, what are the major points? In Bohr's physiological dead space, we use alveolar PCO2, whereas in Enghoff's modification, we use arterial PCO2. Here we use the CO2 from the alveolar side of the alveolar capillary membrane, whereas here the CO2 is used from the mixed blood from the alveoli. So it is the other side of the alveolar capillary membrane. Bohr's physiological dead space is before the effects of shunt and the venous admixture on PaCO2. Here, it is after the effects of shunt and venous admixture in Enghoff's modification. So Bohr's dead space is an index of true dead space, whereas the Enghoff's modification of Bohr's dead space is a true dead space, as well as any condition that contributes to the elevated PaCO2, such as a shunt fraction or any condition where the CO2 is elevated and is not accompanied by an increase in CO2 elimination. The Bohr's physiological dead space is affected by high tidal volume and of course P, and it is also affected by hypovolemia or pulmonary embolism. So these are some of the important characteristic features of Bohr versus Enghoff's physiological dead space. Now, when you measure both during a clinical scenario, when the PaO2 by FiO2 ratio decreases, then there is a widening of Bohr's and Enghoff's values. That means there is a greater deviation from these two values whenever the PaO2 by FiO2 ratio is smaller. And this is a very important information for us in our ICU critical care patients. So what are the advantages of simultaneously determining both dead spaces in critically ill patients with high VD by VT? It's a useful complementary information. Determines the effect of shunt and the VQ inequality versus true dead space in a critically ill patient. Bore's dead space could be monitored continuously without breath gases using volume capnography. And the difference between the two helps us to gauge the progress of the recovery in a given patient. That is why now there is a thrust to use Bore's physiological dead space being determined non-invasively with, with volume capnography in intensive care patients. Actually, this is a small device which actually measures the volume capnography, which actually gives you a volume capnography with all its components. And remember, and this device is very interesting. This is a side stream capnography. Actually, most of the volume capnography devices are mainstream, whereas this is a side stream capnography which has been tailored to give these values. As you can see, it gives you the CO2 waveform. It is also plotting the respiratory flows, which I alluded to, when we were talking about the way where the expiration actually ends in a capnogram. And it gives you all the values of physiological dead space. And it also plots the CO2 concentration against expired volume, giving you the volume capnogram. So we have a time capnogram, we have a volume capnogram with all its components of physiological dead space. And it also gives you the flow volume loops at the same time. And it gives you additional information about the Fowler's dead space, the Cummings dead space, and also the Bore's dead space and Bore's and Enghoff's modification of Bore's dead space. So nowadays these devices are coming into our clinical practice, where we can actually measure the components of physiological dead space non-invasively, breath by breath, in the ICU patients. And there are several studies in literature where the Bore and Enghoff's dead space equations have been used in mechanically ventilated patients in children, and also even in patients with respiratory distress syndrome. What about capnography in neonatology resuscitation? In a study of attempted intubations in neonates, capnography identified all 40 tracheal intubations correctly and all 11 esophageal intubations with 100% accuracy. And it is very critical that we intubate the newborns correctly in order to have good resuscitation outcome. And that is the reason some of the neonatology units have already started using capnography during neonatal resuscitation, and also continuously monitoring ventilation in the neonatal ICUs. Now, postoperative analgesia and sedation is a very important aspect of our clinical management. We all know that untoward postoperative respiratory depression has produced even deaths in some patients. As you can see, these are some of the patients who died postoperatively because of postoperative pain management with narcotics and sedatives. So there is the thrust and some recommendations to use capnography during post-operation, during post-operative period to monitor ventilation. And this is in this study, basically they used capnography and they were able to detect some of the respiratory events, and that led to the calling of the rapid response team during post-operative period. So it's just to show that it is necessary to monitor ventilation in post-operative patients, particularly when they are getting narcotic agents. And capnography is one of the modalities that has been suggested for this arena. And the last one is, of course, the transport of patient. Now, capnography is essential to monitor not only ventilation, but the cardiac output during transport of patients within the hospital and from hospital to hospital. And many institutions, they use capnography. In fact, many states in United States mandate the use of capnography by the ambulances or or the first care providers in the field area too. So, they are actually taking full advantage of capnography, not only during intubation, but also transport to the emergency departments and other institutions. So these are the various landmarks that has occurred in capnography in the last 3 decades. And what is the future of capnography? The use of capnography outside the operating room will increase tremendously. Physicians from other specialties are exploring the value of capnography at rest and exercise in patients with heart failure, whether it is a sensitive device to determine if the patient has got a heart failure. Substantial training of physicians and nurses and the respiratory therapists will be needed if we are going to implement capnography across. Manufacturers need to provide reliable, cost-effective, and portable units capable of quick display. And capnography should be a default in all ICU ventilators, because I just showed you what are the advantages of capnography in ICU patients. And ICU training, because particularly in the ICU, training is required to prevent contamination of the senses, because what happens is the sensors get contaminated with the water vapor and secretions. But however, if you follow certain logistical processes, you can actually minimize the contamination and blockage of the side stream tubes of the side stream capnography. Anesthesiologists should be the forerunners in helping to deploy capnography outside the operating rooms, because in an institution, anesthesiologists probably have substantial knowledge of capnography because they use capnography in the operating rooms as a standard of care in every patient. And therefore, we are in a better state to help the institutions to implement capnography across all areas, particularly the sedation providing areas in an institution, to enhance the patient's safety during procedures. Thank you.